would now like to introduce to you our distinguished KOL, Dr. Lauren Hayes. Dr. Hayes is Vice President of Clinical Operations for the Wound Technology Network. And as you can see from the number of letters following her name, Dr. Hayes is an impassioned healthcare professional, a clinical leader, clinician, and educator with a record of key accomplishments in the healthcare industry, including advanced practice nursing, having received the Nurse Practitioner of the Year Award from the South Florida Council of Advanced Practice Nurses in 2004. She is a wound care and clinical consultant and educator regarding appropriate wound management of patients within a variety of settings, including hospitals, outpatient, skilled nursing facilities, long-term, and home health care. Dr. Hayes has focused research on geriatric care and improving the quality of life in patients with chronic venous leg ulcers. I would now like to ask Dr. Lauren Hayes to take it away.
Thank you, Beth, for that nice introduction. Good afternoon, everyone, and thank you very much for joining us today for this topic, Chronic Venous Leg Ulcers, Improving Outcomes and Quality of Life for Your Patients with BioGuard. So chronic wound statistics, let's take a look at these. Chronic wounds affect approximately 5 to 8 million Americans with a cost of upwards of $25 billion annually. What this slide is depicting is that pressure ulcers, diabetic foot ulcers, and venous leg ulcers are the most prevalent wounds that we see, affecting 1.8 million Americans. And for this slide, we're noticing that outpatient in the home health environment establishes the percentage of chronic wounds that we deal with. Note the 0.7 segment. Those are the other wounds, and predominantly in our practice, those other wounds are arterial wounds or dehisced surgical wounds, as well as some of the atypical wounds. So we have staggering rates, unfortunately, where chronic wounds, which include venous ulcers, result in 40 million inpatient surgeries and 31.5 million outpatient surgeries per year. Keep in mind that chronic wounds are rarely seen in anyone healthy. According to Sen, the author of the article where these statistics came from, the prevalence of venous leg ulcers is greater than 600,000 annually in the United States, costing approximately $9,600 per wound to treat. So who gets these venous leg ulcers, and what are the risk factors? And I want to share with you that the next 4 or 5 slides are I want to appreciate Dr. Robert Kersner from the University of Miami. He has allowed me to use some of these slides. This information is well known in the literature. I just liked how his slides were put together. So who gets these leg ulcers? Older people, women, patients that are obese, people with a history of deep vein thrombosis or blood clots, leg trauma, including our fractured hip patients, for example, jobs requiring prolonged standing, such as grocery store clerks. And up to 1/3 of the treated patients suffer 4 or more episodes of recurrence. Imagine that, 4 or more episodes. So the reality of the venous leg ulcers. The prevalence by gender and age varies. Our gender differences, we notice that they are 2 to 3 times more prevalent in females. And the age differences in this particular study, or studies I should say, notice that the prevalence increases with age, with the peak prevalence between the ages of 60 to 80 years. Of those, 72% of these patients have their first ulcer by 60 years of age. Researchers concur that they estimate that the prevalence of 1.7% are seen in the ambulatory elderly, which is generally over the age of 65. So who develops these leg ulcers? You can see that there was a large study by Margolis et al., where nearly 75,000 subjects. Again, we can see that the percentage with venous leg ulcers peaks in the percentage between the ages of 60 to 80 years of age. So the reality of venous leg ulcers, what do we see when we're treating these ulcers? We all know that venous leg ulcers are weepy or exuding, forming bacteria that gets reintroduced into the wounds, especially during dressing changes. These wounds are large, painful ulcers. They have severe inflammation, odor and swelling, and permanent skin changes. What is the impact on quality of life? Well, when I was doing my research for my doctoral degree, I focused on quality of life in patients with venous leg ulcers. And what we looked at in this study was the psychological, physical, social, and functional domains. And because this webinar is focusing on improving the outcomes and quality of life, let's look at the impact on quality of life in each of these 4 domains. For the psychological, we see the high rates of anxiety or depression or just a feeling of hopelessness or fear. Severe pain and exudate and odor and sleep disturbances are found in the physical domain. In the functional domain, disability, dependence, difficulty with activities of daily living, or decreased work capacity is seen. And in the social domain, there's increased isolation, loss of mobility, and embarrassment. And the impact of venous leg ulcers is worsened by long healing times, especially with the high recurrence rate. And of course, note, infection impacts all of these domains, increasing the isolation, the embarrassment, the pain, the exudate, the sleep disturbance. So what is the impact on quality of life? Specifically, Herendeen found that 97.2% of the patients reported functional restrictions, as we just said in the last slide. 66.7% reported that their mood was affected, again with depression, social isolation. And most felt that the ulcers never seemed to heal. Most worried they would never be free of the condition. I know in my research when I interviewed the patients, that was one of the things they complained a great deal about. Is this ever going to heal? When am I ever going to get rid of this problem? And what unfortunately we found is that, as I said, the recurrence rate is astronomical with 2, 3, 4 times of recurrence. So we know not only anecdotally, but statistically as well, that having a venous leg ulcer does impact quality of life, and often in more than one domain. We as clinicians are working to help the patient's wounds using a variety and a number of different products and modalities to help heal them. So all of us should be familiar with this particular slide. What we're seeing at the bottom of the slide is the contamination, colonization, critical colonization, localized infection, spreading infection, and systemic infection. I would like to say that predominantly we see the patients with the venous leg ulcers right in between the critical colonization and the localized infection. Note that the definition of infection, but also when the intervention is needed, it's needed then between the critical colonization and the localized infection. And during critical colonization, which usually can lead to a localized infection, that happens even without our classic signs and symptoms of infection, the rubor, the pain, the increased drainage, etc. So let's talk a little bit about this and what factors come into play to protect our patients from infecting. With BioGuard, we are interested in preventing reinfection or reintroducing bacteria into that wound bed. With BioGuard acting as a physical barrier to protect the wound from reinfection, what we're doing is essentially we are breaking the cycle. Superbugs. So what are the superbugs? We've all heard that term before. MRSA, DRE, CRE. We know that when a patient has any of these superbugs, there's higher rates of morbidity and mortality. They're more difficult to treat with antibiotics, even without being drug resistant. And we know that these common superbugs occur oftentimes in these venous leg ulcer patients. And unfortunately, many of our venous leg ulcer patients have concomitant arterial insufficiency, or as we like to call it, mixed disease, where antibiotics are ineffective because they can't even get down to the site, whether they're PO or IV. So the contaminated environments is something that we're looking at in this presentation. This is in the hospital setting, where we have methodologies to protect the patient from the superbugs. Yet note on this slide, the percentage of MRSA can be as high as 44%. 50% of the surface and 40% of the air samples of bacteria with colonized wounds were positive for bacteria during a dressing change. Imagine if we took an air sample from a home setting where most of the venous leg ulcers that are treated. Remember, as I said earlier, 40 million surgeries are performed annually on chronic wounds. So again, those patients are in the inpatient setting, again, being exposed not only to the bacteria from their own wounds, but perhaps even bacteria from other patients' wounds. So let's look at the direct and the indirect transmission. On the left-hand side, what you're going to see is the photo of a home setting, and on the right-hand side, an inpatient setting. So we have a contact between the healthcare worker, the patient to patient, and the environment to either. We have the indirect transmission. where the organisms present on the patient's skin or have been shed to inanimate objects in close proximity, such as clothing, bed linen, things like that. And these organisms must be capable of surviving for at least several minutes on the hands of the personnel. Hand washing, as we all know, is paramount in preventing any kind of transmission of any kind of infection. And hand washing or hand antiseptics by the healthcare worker must be inadequate or omitted. Otherwise, we wouldn't be seeing some of the infection that we see. And finally, the contaminated hands must come into direct contact with another patient or an inanimate object that will come into direct contact with the patient. You know, we also believe that any of the bacteria that ends up on the healthcare worker's clothing can also be transmitted to other patients. Opportunist pathogens. So take a look at what we're seeing here. What we're seeing is an obvious leaking or strike-through of drainage on a patient with Pseudomonas on the left-hand side. This is when traditional gauze was being used. And notice how it is a breeding ground for bacteria. On the right-hand side, you can also see some strike-through or drainage. It's not quite as obvious, what the bacteria might be. But I can tell you that this is only after 24 hours. And unfortunately, what we're seeing is with these heavily exudating wounds, the bacteria is spreading onto the bed linens and hence also likely onto the healthcare workers' clothes as well as their hands. So what happens with the transmission of bacteria during the dressing changes? So this data comes from the inpatient setting. So the colony-forming units, or the CFUs, are prevalent in the air just after 30 minutes. This, again, is in the inpatient setting. So during a typical dressing change, or typical gauze dressing change on a moderately dry or colonized wound, what they found was approximately 350 CFU, colony-forming units, of Staph aureus of bacteria were released or aerosolized per liter of air at 2 minutes after the dressing change, increasing the potential of cross-contamination. It's interesting to note that the acceptable range per the CDC of bacteria in the air in general is 200 to 300 CFUs per cubic meter of air. So what we're seeing here is that before the filtration system can even act, you have 350 CFUs over the CDC acceptable limit in the air during the dressing changes. And this is in 2 minutes. The bacteria is alive and has nowhere to go, but on the bed, the linens, the healthcare workers' clothes, etc. There is no filtration system in the home, so imagine what's happening there. Stand guard. So this is the BioGuard, or the Dermasciences BioGuard campaign. They want to stand guard against opportunistic pathogens including MRSA, VRE, CRE. The product BioGuard is a non-leaching, non-toxic, and non-resistant product. It is a broad-spectrum barrier protection that you can rely on. So how does this work, the physical mechanism of action? The physical mechanism of action is, think of a product that perhaps you're a little more familiar with, maybe the Curlex brand of antimicrobial gauze. It's PHMB is the product that's in that gauze, and it works in the same way, where the sodium ions in the bacteria are actually attracted to the calcium ions in the polydadmac, destroying the cell wall structures. However, polydadmac is more advanced because it has a higher charge density, which means it is less likely to become diluted or less effective. So what happens is that cationic biocides work through a very physical mechanism of action. The quats attract the bacterial cells, so the cells are being attracted. We'll show you a picture of that in a second. They bind rapidly to the cellular envelope to disrupt the otherwise stable calcium ions, which then chemically destroys the cell wall structures. Polydadmac is a high charge density, which is, as I said, the higher the charge density, the more likely it will not be diluted in high levels of exudate or other bodily fluids. This is what's different than the PHMB. It has a high molecular weight, and it maintains its effectiveness even in the presence of bodily fluids, such as those highly exudating wounds with the Pseudomonas or the MRSA, and also in commonly used solutions. And it has no resistance. So cationic biocides work through the medicine. So let's take a look at the cell destruction. So the bacterial cells collapse after contact with the BioGuard. This is polydadmac within the dressing. On the left-hand side, you see it before the BioGuard. You can see it's very congested, And on the right-hand side, you see after the introduction of BioGuard. So I think this is a great slide to look at because we see here the broad spectrum of highly effective kill rates. Notice the 99.9999% reduction in the bacteria for each of the big ones that we frequently see in not only our venous leg ulcer patients, but in several of our patients, including those with diabetic foot ulcers, pressure ulcers, arterial ulcers, and dehisced surgical wounds. MRSA, Staph, E. coli, Klebsiella, and Pseudomonas, one of our favorites. BioGuard is a fast-acting and long-lasting product, and I think that's important to us because it obviously reduces nursing time and dressing change time. And the activity starts immediately, even in a high-challenge environment. What this slide is depicting that is within 1 minute, there is a greater or equal than 3 log kill against staph. And I think what's also important is down at the bottom, you'll see a little asterisk where it says it was tested in 10% bovine serum. And what this is it creates a more realistic environment or is more representative of the actual wound bed environment. So this is really a good slide in understanding that it's by testing it in the bovine serum, it's like testing it in vivo rather than just in vitro. So the BioGuard Barrier Dressings, there is a full line of barrier dressing protection for your patient's care. Let's take a look at some of the clinical applications. Well, the clinical applications for this is it can help reduce the wound odor. Hence, we're going to improve our quality of life for our patients. Frequency of dressing changes, that's good for everybody. And the spread of bacteria from foul dressings to the patient and the clinical personnel. It can also help, as I've said several times during this presentation, it inhibits the cross-contamination, patient to patient, patient to clinician, and patient to environment. I hope I'm driving that message home. And it offers a physical barrier to bacterial contamination in environments where you don't have quite as much control, such as in our practice, which is mostly in the home setting or even in the nursing home setting, or, for example, in an ALS setting. So let's take a look. You're seeing some of these pictures again. So the gauze bandages with bound antimicrobial polymer suppress bacterial growth in patients with heavily exudating wounds. On the left-hand side, it's 24 hours after the gauze, and you see, look at the large amount of that Pseudomonas drainage there. On the right-hand side, you're seeing 24 hours after BioGuard. Yes, I still see some strike-through, but certainly there is far less of that strike-through. What does that mean to me? That means there's going to be less odor and less green drainage and less contamination onto the bed clothing, the healthcare workers' clothing, as well as the healthcare workers' hands. Again, additional clinical applications. So here again are some other gauze bandages with a bound antimicrobial polymer suppressed bacterial growth in patients with heavily exudating wounds. You can see in these pictures again some of the strike-through that we're seeing. But after 24 hours with BioGuard, which is on the far right, you're seeing no odor and certainly none of that green drainage. It's a little hard to see in the first picture on the left, but there is some greenish drainage there. And on the right-hand side, it has been eliminated. I'd like to talk about some of the cases that have happened in our practice. I'm grateful to our clinicians that have shared these with me. And the first one is this 68-year-old male who had a history of recurrent chronic venous ulcers for over 15 years. He's had multiple skin grafts and topical treatments, and on admission, the initial treatment was a silver product and compression. Not a surprise to me. Well, we introduced BioGuard, the non-adherent, when it was initiated in March of this year, and his leg was then also wrapped with BioGuard. So not just the square, but we also used the conforming wrap. And then we followed it with a 2-layer compression wrap, which again is the gold standard for anybody with a venous leg ulcer. The wound progressed nicely after this initiation, and it went from 5.9 by 3.1 to 0.3, and then in June it was down to 3.2 by 2.7 by 0.1. People that are not familiar with wounds and how long they take to heal may not think this is a big difference, but those of us in wound care know this really is a great improvement. The second case is a 52-year-old male with a history of DVT, so we already know he's at risk for not only developing a venous leg ulcer, but additional venous leg ulcers, and the subsequent venous leg ulcer formation. Initially, he was treated with Silvadene, which we don't know why, because Silvadene's wet and venous leg ulcers are wet, so we have wet on wet, so right away we're not treating this wound properly. And he was also treated with PO antibiotics for an infection. Well, we initiated the BioGuard and compression in April of this year, and we demonstrated healthy progression with the measurements in April being 2.5 by 3.8 by 0.1, and then again in June it went down to 0.5, 0.5 by 0.1. A really great change for this particular patient. Next case. So this was an interesting patient. This is a patient that we have that actually we are seeing for a breast wound. And when we went to see her one day, we noticed that her lower extremities were edematous, but predominantly her right lower extremity was edematous and it was weeping. And what we noticed is obviously she had cellulitis and edema to this left lower extremity. So typically what we see in our practice is a PCP gets notified and they ship the patient right off to the hospital. So in an effort to prevent hospitalization, which is always a good thing, whatever setting that you're in, if we can prevent hospitalization, the PCP was notified and we convinced the PCP to allow us to initiate PO antibiotics and topical wound care treatment. Our patient had gotten this wound initially by hitting her leg on her walker. And she did tell us that since the last time we had been there, her leg had been weeping fluid and she had just been drying that with some paper towel. So the associated wound, which was fairly superficial, measured 1 by 2.4, and there was no appreciable depth. So as soon as the wound was discovered, BioGuard was initiated, and what we have noted has been helpful in reducing erythema as well as the healing of the wound. This patient has done very well with this, and she's been very pleased, not to mention thrilled to not go to the hospital. And this is my last case, and this is a really interesting case too. This is a 58-year-old patient who was found in his home on top of his bicycle in February of 2014 by his father, who had not heard from him for a few days. He was taken to the hospital, and his wounds were found after a full body assessment. And when the wound that you're looking at is a chest wound, the patient was also in acute renal failure and had leukocytosis. Once he was treated in the hospital, he was transferred from the hospital to a SNF, and that was in March of 14. His wound was treated with Santal daily because of the necrotic tissue that was found inside. He was also found to have gangrene in that area. He was on IV Vanco as well as Rocephin. His PCP decided to refer this patient to Wound Tech, our company, for advanced wound care treatment in August of 14. Our treatment continues, and I want to note that you see 5 photographs here, but the picture number 4 was in December and picture number 5 was in June, and that's because the patient had been transferred to a facility where photos were not permitted. However, he did let us take this last photo for this presentation. And you will see that the note, just note the difference. I mean, I don't even have to give you the measurements. You can see for yourself the amazing healing. You can see the scar tissue of how large that wound was and what the healing is now. Initially, we also used some calcium alginate with silver. We did that in November, but then we decided we needed to start some BioGuard, and the wound became a little dry, so we did use some hydrogel, which I have used in other patients and has been very effective. So let's talk about the product usage. We were talking about that very large leg earlier that had the strike through with the Pseudomonas. The large roll of gauze on the left would be an ideal product for that. It is highly absorptive. It's great for ambulatory patients in orthopedics or even with these venous leg ulcer patients that have heavily exudating wounds. They're great for lower extremities. If it's not that heavily exudating and maybe the patient just has that stasis dermatitis, you might consider the conforming bandage, which again is great for ambulatory wound areas, orthopedics, venous leg ulcers. It's terrific for under compression. It provides a great first layer. It's good for first and second degree burns, and the 2 or 3 inches perfect for pediatrics or small digits. And then the last one is the packing strip, and there's several places that you can use these packing strips: cavity wounds, plastic surgery, et cetera, et cetera. I do want to caution you, however, that sometimes people are interested in winding that right through the toes or wrapping the toes in this ribbon. Be cautious, because if the patient has any prevalence of edema, you can actually have too much on those toes, and you can cause a much greater problem if the wound is not gently wrapped and wound in between those toes. So be cautious when you're using that on the toes. A couple of other iterations of this product. We have the Island Post-Op Dressing, which has, of course, it has an adhesive border or a window pane around it. It's seen, we use it a great deal for abdominal wounds, C-sections, head and neck wounds, or any place where an adhesive product would like to be used. The one next to it's the non-adherent. It's great for patients that have sensitive skin that don't do well with any of the adhesive products. And then, of course, we have our ready-cut gauze for burn, and they're good for burn units, donor sites, superficial to deep or partial thickness burns. So in summary, and I think we're just about almost on time here, at the Chronic Venous Leg Ulcers, we like to think about improving outcomes and quality of life for your patients with BioGuard. And we all know venous leg ulcers can really be challenging to manage, especially in the home environment when you cannot control where the wound is being exposed to, cats, dogs, bacteria, other things in the home. And this severely impacts the patient's quality of life. And the impact of venous leg ulcers is worsened by infection, as we talked about earlier. It's affecting all of those domains of quality of life. And when you have infection, long healing times and high recurrence rates unfortunately occur. We need the use of a barrier dressing that can help minimize the risk of bacterial contamination and keep that wound clean. This is important. In fact, it is paramount. We want to keep the clean wound that we just cleaned clean. This is why it's great to utilize that BioGuard after you have cleaned that wound. And BioGuard Barrier Dressings provide a greater than 5 log kill, including MRSA, within that dressing substrate, without toxicity to the healthy tissue. You need to keep that in mind because peri-wound is often forgotten about when people are doing wound care. And I like to use the conforming wrap on our venous leg ulcer patients, those with the stasis dermatitis. I find that that helps eliminate some of that dermatitis just by using that as the first layer under any kind of compression. I want to thank you for your time and your attention today. I am open to any questions.
Thank you so much, Dr. Hayes, for sharing not only your clinical perspective and understanding, but certainly also the background and information on bacteria and infection rates and certainly the cross-contamination issues, because it really is such a challenge that you as clinicians face on a daily basis. So thank you. We do have a number of questions coming in. Again, if you do have a question you would like for Dr. Hayes or myself to answer, please do just type it into the question box. We have a few minutes left and then we'll get you all back off to your patient care. So we actually have a number of questions, so I'm going to kind of condense them down into just a concept. And again, it is the protocol of care and how to manage the drainage that clinicians experience, especially with these more heavily exuding wounds, and what your recommendation would be as far as the dressing to really help to absorb the drainage and then also the use of the BioGuard to protect it.
That's a great question. Thank you. I don't want to just talk about dermasciences, but dermasciences does have a really superior absorbing dressing called Exazorb that we utilize. And what I like to do is I like to use the BioGuard first because it's providing the antimicrobial. And you're putting that down against the wound bed. You can either use the squares, and then you can actually put down some of an absorbent kind of a product. If you don't have the product I just mentioned, a foam, an alginate, even some ABDs, if your facility doesn't have either of the foams or the alginates, can go next. And then you can utilize your BioGuard conforming wrap. So when you're undressing that wound, again, that bacteria is being captured and killed so that it is not floating around the room and onto the healthcare worker's hands, clothes, or the bed linen and getting reintroduced into that patient's wound.
Great, thank you. Also, a couple questions too, which this is a very commonly question asked of BioGuard, and that is really the difference, the use, and the application of a BioGuard dressing versus a silver dressing.
So what is different between BioGuard and a silver dressing? Well, really it's how the products work. So silver dressings, when they are utilized on chronic wounds, actually go into the wound bed and they kill the bacteria. It is a bactericidal, and it does kill the bacteria within the wound bed. Unfortunately, there are patients that do have some resistance to silver, and I think this is happening because we as clinicians were so excited when silver came out probably 15, 18 years ago that we're overusing it. And clinicians are overusing it by keeping it on for longer, for example, than 2 to 3 weeks, which is longer than it should be on. And the reason, as I said, the way it is different is if I imagine BioGuard, again, the idea is to capture and kill. So the bacteria is attracted to the polydacmac. And by being attracted to the polydacmac, what happens then is it's killed within the dressing. It is not killed within the wound bed. So that really is one of the main differences of how a silver dressing works and BioGuard works. You're not killing anything within the wound bed itself. What you're doing is you are attracting the bacteria out of that wound bed, onto that dressing, and by killing it, providing a barrier. I hope that answers the question.
Great. Yes, thank you. So if a hospital is considering bringing BioGuard in, but not necessarily house-wide yet, could you recommend where possibly the targets would be, like surgery or ICU, burn?
Certainly. I certainly would see that post-surgical, and well, actually all those settings would be appropriate for this particular product. Post-surgery, if a patient is having any kind of lower extremity surgery, utilizing some BioGuard, right in that OR, because each of these BioGuard products is wrapped individually because they're sterile. So you can open up that package and you could put it on right there in the OR, and that would be a great way to already prevent any kind of contamination or infection. In the ICU, there is so much bacteria in the ICU. I certainly, I can't even imagine what the CFU count is in the air in the ICU, especially during any kind of dressing changes. So I certainly see that it would be effective there, and of course in the burn units as well. I know in the burn units they use a great deal of Silvadene, and that's, there's many reasons. I am not a burn specialist. My hat's off to those burn specialists out there. But I do see, once the wounds have been treated for a while, I think BioGuard would be great to be introduced. When I said earlier on, if you have a chance to look back at these slides later, you will see near the end we talked about the different varieties of the particular product that's out there. Some of them are really particular for the burns, but they're for the first and the second degree burns. If you're in an inpatient setting and you're having patients with burns, those patients are typically more severely burned. So for an at-home patient with burns, absolutely I can see that, that we could use it for there. But I'm thinking in the hospital, I'm not really sure how that would fit in.
Great. Thank you. We have two more questions here. Thank you for everyone for staying online. I know we are just 2 minutes over our half-hour time frame, but the discussion and dialogue has been wonderful. So actually we do have a comment, Frankie from the Niagara area, thank you, had commented that it appears to be a wonderful product all around, and Frankie is a community nurse. So wondering, how long until the product becomes part of his Niagara Community Access Association. So I will actually have our sales representative for your area get in touch with you. So thank you, though, for participating and your interest. And last comment question is BioGuard can be used directly over the wound, correct?
Absolutely, so it can be used directly over the wound. I'm sorry, Beth, go ahead.
No, I was just going to say exactly. It absolutely can be used, depending on your wound type and your need. I know Dr. Hayes has mentioned, using the gauze sponges and then, cover with a more absorbent dressing. If you have a more sensitive wound condition or sensitive skin type of environment, the non-adherent dressing can also be used first and then covered with another more absorbent dressing and wrapped with the BioGuard. So really depending on what and how your patient's wound is presenting, you do have the option to choose from the variety of BioGuard dressings in that line to really meet the needs of what you need to accomplish for that wound.
And so with the third to last slide shows the post-op dressing. So right away they're using it right away for abdominal wounds and C-sections. So absolutely it can be applied directly to that wound bed. Perfect.
And actually to that point, the post-op dressing uses that non-adherent, with the adhesive border around it. So, so that's excellent. Great. Well, with that, that was our last question that had come in. I would like to thank everyone for their time and participation online with us today. Hope that you found it very beneficial. I would again like to thank Dr. Hayes for her time and her expertise, certainly presenting this educational topic to us. I know infection is something that just really challenges all of you with your patient care and helping to improve the quality of life and environment for your patient and their wounds to heal and heal healthy is something that we are all in the mission to accomplish. So thank you again. If you would like further information, you can go to our website. This webinar webcast will also be available on demand if you'd like to view it online post this presentation. And certainly please do follow up with your area representative for more information, and they can also provide you with samples.